I will be the opening batsman today, and I will be talking about COVID and its associated cardiac risks. So, India under lockdown in March 2020, COVID testing started. Our ICUs got filling with COVID patients. We saw sicker and sicker patients. Migrant laborers struggled to go back to their natives. COVID warrior army got ready, but unfortunately, we lost many lives. This was the horrific scenes which everyone experienced. Many lost their entire families. There were no beds in ICUs, so people were stranded outside the hospital. Many lost their lives outside the hospitals. So what has COVID changed after those days? So we got a new wardrobe, masks. Few people started drinking. Many people got anxiety, depression. Few developed obsessive compulsion disorder of sanitation. Many people got friends through either online or through puppies. There were many rumors, still there are many rumors about COVID and its effects. Temporarily there were lower CO2 emissions during the lockdown periods, but they were not enough to curb the previous effects of the harm which already we have done. Schools were closed. We got a new vaccine. Effect on economy, trillions were wiped out during those days from global economy. But meanwhile, all these gentlemen doubled or tripled their wealth during that time. And if you see the million deaths worldwide in 2019, as compared to that COVID-19 got the fourth place in the mortality chart worldwide. Now coming to the COVID-19 and viral myocardial interactions. So this is a nice depiction when a person gets mild or moderate COVID. This is a clinical severity. Usually the clinical severity peaks by 8th or 10th day. And simultaneously what happens to inflammation, this chart is showing. So inflammation is minimal and it is always below the level of immunity. So immunity has an upper hand in mild to moderate infections, so that virus starts getting cleared after 10th or 12th day. Similarly, coagulation also never peaks and they develop small or no venous clots. But as compared to that, if you see in severe COVID, the severity of the disease goes on increasing until the patient dies or recovers after prolonged hospitalization. Here, the red part, that is inflammation, always has an upper hand over immunity. So immunity peaks at around 10th day, but unfortunately it goes down because of our steroids and various tocilizumab immunosuppression which we are using, and also a part of the infection. So eventually the inflammation takes over the immunity, and that leads to hyperinflammatory phase, cytokine storm, ARDS, other systemic effects, multi-organ failure, and death usually. Even the coagulopathy also follows the inflammation, and it goes on increasing as the duration of hospital stay increases. So this is a complex interplay between the virus and the heart, which eventually leads to myocardial infarction, heart failure, and arrhythmia risk. So to summarize the same thing, we call myocardial injury when there is a troponin elevation of more than 99th centile. So those people can have direct myocardial involvement causing myocarditis. They can have demand-supply mismatch because of mainly hypoxia or anemia causing type 1 or type 2 MIs. Few people who are very sick, they can get Takotsubo cardiomyopathy, also known as stress cardiomyopathy. Pulmonary embolisms were very well known during that period because of venous clots. If somebody had pre-existing heart failure or coronary artery disease or ischemic heart disease, they were triggering heart failure admissions in them. Multisystem inflammatory syndromes were common amongst children. Cytokine storm, we all have experienced their brunt. Coming to RV dysfunction, it was even if the patient did not have left ventricular dysfunction or left ventricular involvement, many of these patients had RV dysfunction. RV dysfunction affects survival in a big way. So why RV dysfunction isolatedly happened was mainly because of acute corpus pulmonale. If somebody had severe pulmonary involvement, they will have RV overload, RV ischemia, that leads to RV dysfunction. Pulmonary embolism, as we all know, RV gets involved, that leads to dysfunction. And also RV myocarditis was happening. In children, what we were seeing was multisystem inflammatory disorder. In them, the most common manifestation in cardiac system was coronary dilatation, also known as Kawasaki disease, and second thing, perimyocarditis or myocarditis. So coming to the risk, whether it has actually increased after COVID, if we see mortality that has happened because of COVID, we can divide it into during COVID and after post-COVID. During COVID, it was due to COVID, and also it was due to fear of COVID. The conditions which required urgent medical attention or urgent medical treatment or let's say surgeries, they were getting delayed. So denying the patient of the essential medical services, causing delay in the treatment, causing mortality. Not directly because of COVID, but indirectly because of COVID, because of the delays. After COVID, there is a post-COVID risk that we'll come and see. What lessons we get from history, in 1918 to 1920, there was an influenza pandemic. In that during those days, 1932 published one paper which mentioned that there was excess mortality which was noted apart from causes other than pneumonia. So even during that time, it was noted that myocardial infarction, venous clots were very common in those people. So this is the official Indian government website where we have, they have lodged 4.4 crore COVID cases till now, and deaths are 5.3 lakhs. Total vaccination done are 2.2 billion. So this is a diagram which shows the course of a patient who doesn't have a COVID, but how they fared during the COVID. If we see, this is a non-COVID case. If he required some intervention, if he gets it in time, then that is the blue dotted line is a natural outcome. But because of COVID, the treatment was delayed, mainly because they presented late to the hospital. Doctors and physicians were fearful of treating them. COVID testing was mandatory, that was getting delayed. The tests were available after 24-48 hours. So that led to delay in the treatment and alter the natural course of the disease. So that delayed the treatment and worsened the outcomes. And many, unfortunately, did not make it to even hospital. So they died, majority outside the hospital setting. So this was one study which was done in my institute during that time, Jayadeva Institute. This is a study which was done during COVID. It involved 411 patients. This was in first wave. So this had 411 patients in the 3 months, out of which diabetes was present in 42% of the patients. Acute myocardial injury, that is troponin T elevation, was noted in 63% patients. Heart failure was there in 61, and eventually 15% died. So this is a cardiac center which is depicting a 15% mortality, quite higher than non-cardiac center. So this is a recent paper which is published 10 days ago, October 19, 2024. This says COVID-19 infection appeared to increase the risk of heart attack and stroke up to 3 years later. So 3 years later is now. The risk was also higher among people with A, B or AB blood group types compared to type O blood groups. So this study this is the original article. So here the title is interesting. COVID-19 is a coronary artery disease risk equivalent according to author. How that we will come to see. Exhibits a genetic interaction with ABO blood types. So this is a nice line diagram. Here there is a time of events according to days from 0 to 3 years, that is 1,000 days. And here is the incidence of myocardial infarction, stroke or death on y-axis. So if you see red line, the top one, which has COVID positive patients also and cardiovascular disease patients. So if you have both of them, the risk of getting MI, stroke and death is almost 40% at the end of 3 years. If you don't have either of them, if you never have got COVID-19 infection and you don't have cardiovascular disease, your risk of getting all these three things is 2%. That is normal. If you have either of them, if you have one of them, then the risk is almost equal. That is around 20% at the end of 3 years. So same thing I have tabulated. So if both of them are not there, the risk is 2% at the end of 3 years. If both of them are there, then the risk is 40%. If one of them is there, then the risk is 20%. So if you see COVID, if you are getting COVID infection in the last 3 years, you are having similar risk as a person who is having cardiovascular disease. That is 20% of having MI or stroke or death. This is the recent study. Similarly, blood group, according to blood groups, if you have not got a COVID infection, the black lines below, that is the normal people who have 2% risk at the end of 3 years. But the above red line is for A, B and AB blood groups. If you see in them, the risk of getting MI or stroke is around 7.5%. And in people with O positive blood group who have got COVID before, they have only a 4% risk. So same thing tabulated here, 4.5% amongst O positive people who have got COVID in the past, 7% approximately in people who have got COVID and who are either A or B or AB blood group. This is another study which is recently published, and it compared whether diabetes has any role in the development of cardiovascular disease in the future. So this said that irrespective of diabetes, if you had got COVID in the past, your risk of CVD remains increased. This is a good study from one tertiary care center in India. This is 2 years before COVID pandemic. Their mortality was 1.2%. 1 year before COVID, their mortality is 1.38%. In the first year of COVID, their mortality actually decreased because patients coming to them had reduced actually. In the second year, they had a spike in mortality. Their mortality almost double. And now after, in the third year of COVID, their mortality has again come down to baseline. So that means the cardiovascular disease death is pre-COVID and post-COVID is still same, even though COVID caused some increase and decrease in between those 2 years. So does vaccines pose any risks? So many vaccines were available during that time. So as we saw, Indian figure, 2.2 billion vaccination doses are delivered till now. So most common side effect which was noted was myocarditis or pericarditis, which was seen in 12.6% of the 12.6 cases per million. That translates into 0.001% of the people who got vaccine. So that is minuscule as compared to people, that is 450 cases per million when the person is actually infected. Blood clots also, 66 people with vaccine got blood clots. 12,614 people got blood clots when they got infection actually per 10 million things. So red dots are the people who, if they are not vaccinated, and their risk reduces by 10 folds when they are vaccinated. So if you take a patient who is 50-year-old, if he is unvaccinated, and if you take a patient who is 80 years old, if he is vaccinated, their risk gets equalized. So vaccines gave us that confidence to fight the pandemic. So these are my take-home messages. COVID is in the past now. Why do I say that? Because COVID has gone, it has increased CV risk definitely, but that increased CV risk we can't manage from the COVID perspective. We have to manage it like any cardiovascular disease. Treatment doesn't change. COVID infection has been shown to be equivalent to coronary artery disease risk equivalent, as we saw. Though COVID appears to increase CV risk, treatment doesn't change for ischemic heart disease or cardiovascular disease. Hence, time has come to move on from COVID. Maybe in future, if there is any literature, we can discuss that. COVID vaccines were effective and are as safe as any other vaccines. May I have your attention for 2-3 minutes more? Again, coming to the same slide, which caused death in COVID deaths were around 5.3 lakhs in Indian population. These are official figures. Unofficially, many articles you can get around 5 times more mortality or 10 times mortality, which are not reported. But we don't know what is correct, what is wrong. But we'll assume that this is correct. This is again a WHO website which says in 2023 Indian population was 1.4 billion. This is a 2019 figure. The top causes of death, the disease on the top is ischemic heart disease. That leads to 113.5 deaths per lakh population. That translates into 16 lakh deaths per year. So in summary, COVID have caused 5.3 lakhs in those 3 years. Ischemic heart disease kills 16 lakh people per year. So what happens in ST elevation MI is you have a plaque. When that plaque ruptures, you get a clot over that. You get a coronary artery occlusion that leads to ST elevation MI. So what is the best treatment for ST elevation MI? What is the fastest, safest and best treatment for ST elevation MI? Most of us know, many of us don't know. So if patient presents in less than 12 hours, primary PCI is the gold standard treatment and last one recommendation, and it should be done within 2 hours of reaching to the hospital, not from the symptom onset. If by any reason primary PCI cannot be offered, thrombolysis is the next option. And even after thrombolysis, patient is supposed to get shifted to the PCI capable center within 24 hours, and he should undergo angiography and angioplasty within 24 hours. Even if the patient presents after 12 hours, then there is only option of primary angioplasty. Why I am emphasizing this is because the problem with India is patient receiving primary PCI in India is 5%. If you see figures in Western countries or European countries, the figure is 95%. So what is happening wrong? So first, we are thrombolizing 95% of our patients in India. Maybe physicians who thrombolize do not know that primary PCI is the best therapy that can be offered to a patient to reduce mortality, morbidity, and increase survival. Cardiologists' inertia to do primary PCI and failure to create awareness regarding importance of primary PCI. Also, even the people or the population per se do not have that education or awareness about ST-elation MI or myocardial infarctions that require primary PCI. So this is our problem, that we are missing on 90% of the primary PCIs. Thank you.
Excellent presentation by Dr. Lokesh Chaoudhary. And now the session is open for questions.
Just before opening for the questions, few remarks. Actually, it was a very nice presentation by Dr. Lokesh. Now, atherosclerosis, which is a backbone of MI, it is considered as a chronic inflammatory disorder. And because inflammation is the common point between infection as well as the atherosclerosis, there are a lot of studies and a lot of trials which show that the inflammatory disorders like rheumatoid arthritis can have approximately a hazard ratio of 1.5. So anybody who is having active rheumatoid arthritis can have a 1.5 times more incidence of myocardial infarction as compared to the normal population. And it goes more to the infection. The association is more proven with influenza, where there is a 400% increase in the incidence of the myocardial infarction after getting influenza, especially 3 days, because the activation of the inflammatory cytokines, it produces a plaque rupture and it leads to acute myocardial infarction. So the recommendation from all preventive guidelines is to vaccinate against influenza, especially patients with a heart failure and reduced ejection fraction. This is a class 1A recommendation. Now coming to COVID, there was a paradox. In the acute COVID, there was a reduction in the incidence of the acute myocardial infarction. However, in the late phase, there was increase, substantial increase. However, if you see, I will just quote one study. It was a study from Veteran Administration of the US. And what they studied were 1.5 lakhs of the people who were under Veteran Care Administration who had COVID. And they compared as a control to the remaining 56 lakhs of the non-COVID patients. As well, they had taken a pre-COVID control group. In 2017, 58 lakhs of US administration, this veteran administration patient, and they found that the incidence of MI after COVID increased by 1.6 folds after acute COVID. So the incidence is not much. Actually, there is a lot of misconception among general population. A lot of people who are diabetic, they are smokers, and they ascribe their incidence of MI to a past COVID, which has happened 4 years back. So in conclusion, we have to have some kind of an preventive strategy. The first strategy is a prevention. As he rightly said, the vaccination definitely prevents severe COVID, and severe COVID is associated with more increase in the acute myocardial infarction. Recently, there are a lot of things which has come in the cardiology. The first thing is a colchicine. Previously, it was used to treat only pericarditis and gout. It has come as a preventive strategy for prevention of acute myocardial infarction in cardiology, and it is considered as a class 2B recommendation in recent cardiology guidelines of prevention. And it prevents myocardial infarction because of its anti-inflammatory mechanisms. However, it is also associated with increase in non-cardiovascular mortality. And the second most important thing for a general population or a lay public, it was again a study from Veteran Administration. It was published in 2022, and it was a very large scale study. It included 750,000 patients, observational studies, and these patients had a treadmill because of some reason or the other, and they were followed up for 10 years. And what they found was there was two aspects they studied: the importance of a positive cardiovascular risk factors, for example, hypertension, diabetes, and their negative association with the mortality, and positive aspects of exercise. And what they found was that if somebody is having a hypertension, the risk of death will be around 14% as compared to non-hypertensive population. If somebody is having a diabetes, the risk of having a myocardial infarction or the death will be 28%. If somebody is having a smoking, then it will be 40%. Whereas if somebody is a non-exercises as compared to the most fit people, the incidence of having a myocardial infarction will be 400%. So in a general population, if we are talking about a risk factor reduction, then exercise is the most important thing, and we have to advise and positively recommend exercise as the first line treatment for all these kind of mortalities and morbidities. Thank you.
This session has been sponsored by Department of Cardiology, Aster Radar Hospital.
Your talk was very good. I just want to ask you one question, very practical. That article is very an eye-opener, which you showed. So COVID positive 20% at 3 years. So the practical question is, if a patient asks you, all of us, should we give preventive echosprin to these patients? Because of this data now, we were not giving, but now 20% is an alarming incidence. So what is your recommendation?
So this is one article which says that this is a coronary artery disease risk equivalent. As we all know, diabetes, hypertension, dyslipidemia, CKD, all are established CAD markers. In them, statins are recommended. Eventually, when we get more and more data, more and more research about COVID-infected patients, we might get a approval for statin use first, and then maybe aspirin later. But data is awaited. We don't have data as of now. It is only labeled, maybe this is hypothesis generating. We have to get a RCT or observational study later on.
Just last question, please. Yes.
Is that your prescriptions have changed after the COVID about the vaccination? Because it's all inflammation. And if you remember, one of the conferences here, Dr. Dixit from our area had said that the preventive cardiology should have a vaccination program into the, so do you have a prescription in your preventive cardiology prescription that this should be the vaccination program?
So 2 vaccines recommended for any patient who have ischemic heart disease or heart failure is pneumococcal vaccine and influenza vaccine. They are to be given. I give them mainly to people who have reduced EF, heart failure with reduced ejection fraction. To other people, I don't force them, but I usually mention on paper most of the time, but sometimes I forget.
In US guidelines, they recommend for all people 2024, 2025 COVID vaccine, which is a booster dose. Now in India, it is not available. So to recommend to our patient COVID vaccination, it is something hypothetical. However, in the US guidelines says that if somebody is high risk, somebody is more than 65 years of age or a healthcare professional, should have a 2024-25 booster dose. Because of a change in, just like an influenza vaccine, the valency of the vaccine is changing every 1 year.
Now, after 65, the Indian government also has given the concept that all should be vaccinated for influenza and pneumococcal.
Yes, so yes. All people who are having some kind of a respiratory disease, liver disease, kidney disease, and heart disease also.
I'm talking about coronary.
Yes, yes, coronary. The recommendation is for all patients of established cardiovascular disease, especially for heart failure patient with a reduced ejection fraction.
COVID incidence also has come down. I took out our data from our Aster Radar. In this year till October, we have got only 16 cases of COVID positive confirmed cases by PCR. But pneumonia, we are getting more than 100 cases per month. So out of pneumonias, if we till October, we should have had more than 1,000 cases. Out of them, only 16 were COVID positive by PCR. And fortunately, I think 1 or 2 only have died out of them.
Now I request our chairpersons, Dr. Chandrasekhar Patil sir and Dr. Amol Dharmadhikari sir, to felicitate our speaker.